Welcome back to Neuroscience. Let's go into great detail of the medulla. So the medulla is a part of the mesencephalon, which is going to be part of the midbrain, and it contains the primary vital centers, which is going to be your heart, your mobility, and your breathing centers. And they are all interconnected to cranial nerves 9, 10, 11, and 12, and at the medulla-pontine area, so where the pons and the medulla meet, is going to be the cranial nerves 6, 7, and 8. And the external features, there's going to be the anterior median fissure, and at the bottom is going to be the foramen cecum, or up here would be the foramen cecum. Sorry, this is the olive. This is the external arcuate fibers. Here's the medulla. So there would be here like cranial 6, 7, and 8. More importantly, foramen cecum is going to be your vomiting center. And then at the end, or at the lower end, here are the pyramids. Beside it are the olives, but the pyramids are where the fibers will cross or decussate, and that's also where the anterior external arcuate fibers will pass through. So on the ventral surface, there is going to be the cortical spinal tract that goes right through the pyramid, so it comes from the spine, and there's two decussations. So it's going to cross at the medulla and then go up, and then somewhere in the brain, if it's per certain function or a certain motor area, it could cross again, but it crosses in the medulla. And that is going to be the lateral, and this is going to be the anterior. Anterior doesn't cross. So it goes through the olive, which is going to be involved in the motor learnings as it goes to the cerebellum. And then at the anterolateral sulcus, the hypoglossal nerve is going to be there. And then at the posterior sulcus, there's going to be cranial nerves 9, 10, and 11. Hypoglossal nerve is cranial nerve number 12. Cranial nerve 11, the accessory nerve, has both roots. It has a root in the spine and one in the brain. So as you can see here, the lateral spinothalamic tract is going to decussate, crosses, and then the anterior is just going to go straight up. So, and then they'll do something else in the cerebellum, so don't have to worry about that quite yet. Anyway, it's important to know that like both anterior and lateral, as long as they're the cortical spinal tract, this is involved in motor fibers. So on the posterior surface, so it's hidden behind the cerebellum. So imagine the cerebellum being cut away. It's right below the mammillary bodies, these two. This is going to be superior, this is inferior. And the closed part of the medulla is going to be made out of the gracial tubercle right here, the tuberculum cinereum, or the trigeminal spinal nucleus, so it's right here, and the inferior cerebellar peduncle. So the inferior cerebellar peduncle is going to cover it, right? The open part is going to be the rhomboid fossa, which is like basically this, and then the arcuate nuclei will give rise to the external arcuate fibers. So, okay, what do they do, right? Nucleus gracilis and nucleus cuneatus are going to be involved in conscious proprioceptive sensations. Olivary nucleus, as you can see, it was, remember when we were saying the cortical spinal tract goes through it, so that's voluntary movement. Vital centers, of course, and the nucleus of 9, 10, 11, 12. And then white matter is going to be all the ascending and descending tracts. Okay, so the there are four transverse sections that people can categorize this the medulla in. So the first would be the pyramidal decussation, so right at the pyramid. Second one would be the second would be the medial lemniscus decussation. Third would be the superior half of the medulla at the inferior olivary nucleus, and then fourth would be at the pons level, so like right below the pons. So the medial lemniscus would be a second like tier, then the pons, and then the medulla. See it here. So midbrain, pons, medulla, pyramids. The first level. Okay, so it's similar to the spinal cord with a central gray matter around the central canal. Oh, you can barely tell, but here is the central canal. Here's the gray matter. The decussations will make the pyramid, so it crosses like that. The ventral horn is going to be like getting detached, so it's going to move away, and that makes the spinal tract of the trigeminal nerve right here. And here's the spinal nuclei of the trigeminal nerve. So tract is more lateral, nuclei is in the more medial. And then there is going to be the spinal nuclei of cranial nerve number 11, along with the supraspinal nuclei of the first cervical nerve. Those are a little bit harder to find, but they are more surrounded towards, like, they're more central to the central canal. Oh, sorry. So the efferent of the first cervical nerve is continuous with the nerve above, so it's continuous with the nucleus of the 12th cranial nerve. And then the dorsal spinal cerebellar tract, or the dorsal horn, is going to be made out of the gracilis, cuneatus, and cervical nuclei. And the reticular formation is going to be an important part of the first level, and it's important for proprioception. So here's the decussation of the pyramids. Here is going to be the lateral spinal thalamic tract, which is involved in pain and temperature. Here's the olivaries, spinal olivary tract. So both would be mirror images, but the image is, a little blurry, but they are trying to like differentiate, but like just know both are mirror images of each other. Okay, so at the second level, the nucleus, gracilis, and cuneatus is going to be like more separated. And then there are going to be the internal arcuate fibers along with the medial lemniscus. The internal arcuate fibers are important because they cut off the spinal nucleus and the tract of the fifth nerve, and that's going to help with the crossing of the fibers. And here's the crossing of the medial lemniscus. Here is going to be the pyramids, so they've already crossed, right? Here is the inferior olivary nucleus. This is motor. Posterior spinocerebellar, anterior cerebellar, and here's the trigeminal nerve, cuneatus, fasciculatus. So fasciculus, remember that's just a tract. And we orient ourselves using the posterior median sulcus. And right here would be the fasciculus gracialis. And then the nucleus is going to be like more deep. Central canal is right here. Hypoglossus nucleus is right next to it. So the nucleus tractus solitaris is going to convey cranial nerves 9, 10, 11. And that's going to be the sensory parts of these nerves. The medial longitudinal bundle is going to convey cranial nerves 3, 4, and 6, along with the vestibular cochlear nerve and cranial nerve 11. So it's kind of all lumped in here together, and like I said, it's very close to the central canal. So and the only nerves that are nuclei that is like basically furthest away from the central canal is trigeminal nerve, so cranial nerve number 5. Okay, at the third level, the central gray matter is going to be basically touching the floor of the fourth ventricle. And it's going to have cranial nerve number 12, cranial nerve number 10, and there is going to be the vestibular nucleus, along with the nucleus of tractus solitarius, and the nucleus ambiguus. So that's going to be the motor section, here is going to be the motor parts of cranial nerves 9, 10, 11. And then exteriorly, the anterior arcuate nucleus will cross. Laterally, the inferior cerebellar peduncle is going to be like very close, and it's going to also have the inferior olivary nucleus. So here is cranial nerve number 12, hypoglossal nerve. Here's nucleus ambiguus, so 9, 10, 11. Inferior cerebellar peduncle is basically touching. Right here, trigeminal. So it's starting to spread out and look more like like the spinal cord. So it's starting to be like a butterfly. But here are the cochlear nuclei. So it's going to be involved with like the vestibular cochlear nerve. And right here, here's going to be the vestibular nuclei. So it's very close. Here's the inferior cerebellar peduncle. Spinal cerebellar tract. So we already went through the tracts. Let's concentrate on just like the nuclei, right? Dorsal vagal nucleus, so this is going to be cranial of 10. Here is 12, or wait, hang on. So this is 10, dorsal vagal, this is 10, this is 12. And this is going to be the tectospinal tract. Okay, so at the fourth level, it's going to be right below the pontomedullary junction, and that's going to be cranial nerve number 8. That's basically gonna like appear. And that's involved with the cochlear and the vestibular ganglion. The cranial nerve will synapse with the vestibular ganglion and the spiral ganglion, and go into the vestibular nuclei along with the cochlear nuclei in order to integrate that information and maintain our sense of equilibrium and balance. Okay, so the vital centers. The cardiovascular center is going to regulate the heart rate, the squeezing of the heart, and the vasodilation. Medullary rhythmicity area is going to adjust the rhythm of breathing. So we can control this voluntarily, though. This is the only area that is involuntary. The vasomotor center is the center for vomiting, sneezing, hiccuping. And remember when we were going in anatomy, there's the pneumatastic and apneustic center. So that's all involved with the rhythmicity area. Sorry. So pneumatastic is inhalation and it's going to inhibit each other, right? So it's going to inhibit the ventral respiratory group, and it's going to inhibit the dorsal respiratory group, which inhibits the ventral respiratory group, and these two have to work in tandem because there's also the apneustic center. So as it goes, it's going to help the intercostals and accessory respiratory muscles contract, allowing you to breathe in. And so the apneustic center is going to help you. This is going to be inspiration. Pneumotaxic is going to inhibit that. Okay, so basically everything's supplied by the vertebral basilar system. It comes from the basilar artery, and the vertebral arteries on either side is going to connect and then form it. And then there's going to be the circle of Willis. So the posterior communicating arteries, spinal arteries will arise from the posterior inferior cerebral arteries, and that will supply the fasciculi along with the spinal nuclei of all these cranial nerves. And the cerebellar peduncle. The posterior inferior cerebellar artery is going to supply the lateral part of all the medulla spinocerebellar tracts, along with the descending sympathetic tracts and the nucleus ambiguous. Okay, so the Arnold Chiari malformation, there's actually like 4 types. Arnold Chiari malformation is the second type, and it's basically the congenital herniation of the tonsils through the foramen magna. And by each type, it's going to be how bad it is, right? So this might be just like a little bit of the tonsils poking through, but in specifically Arnold Chiari malformation, it has to be both herniations of the tonsils and the medulla. Problem is, it's going to like cause a kink in the medulla and cause a blockage in the CSF flow, producing hydrocephalus. And here are the signs. So as a clinician, what do you see, right? So you're going to see in their eyes, it's going to be very red, it's going to be inflamed, and when you look into it, there's going to be a lot of changes to the retina. So that's the papillary edema. There's going to be the sunsetting eyes. So when you try to make the child look up, they can hardly move their eyes up. It's going to automatically drift downwards. The kid's going to be just crying and sick and upset. It's going to be involved with the vomiting, because remember, in the medulla there's going to be that foramen cecum, and that's what I said was the vomiting center, and it's so close to the base, so if it herniates through, there's going to be pressure on it. Increased head circumference from the hydrocephalus, of course. Headache due to the hydrocephalus, and the dizziness too. Okay, so in the vascular disorder, there's usually a thrombus of the posterior, inferior, cerebellar, and vertebral arteries. In a lateral medullary syndrome, it's going to be Wallenberg's syndrome. So it's going to be a Pica syndrome. Vertebral arteries usually affected. Posterior, inferior, cerebellar artery is affected. So what's going to be happening? The Horner syndrome is going to occur. So decreased pupil size, droopy eyelid, a lack of sweat, the double vision, slurred speech, dizziness. The hypoglossal nerve is going to be affected, of course. So that's going to be the slurred speech. And the medial medullary syndrome is going to be Dejeron's syndrome. As you can see here, this is the places that's going to be affected. Right, back to Wallenberg syndrome, Pica is going to be involved. So it's going to involve the spinal thalamic tract, cranial nerve number 5. So this is going to be an issue with the eyes along with the mid-face. Nucleus ambiguous, inferior cerebellar peduncle, vestibular nucleus, and descending sympathetic path. So there's going to be ipsilateral loss of pain and temperature sensation over the face, because it's involving the cranial nerve number 5 and the spinal thalamic tract. So spinal thalamic, pain and temperature. Face, because of cranial nerve number 5. And it's going to be ipsilateral paralysis of the palate, pharynx, larynx, and absence of the gag reflex due to a problem with the descending sympathetic path and the inferior cerebellar peduncle. Ipsilateral ataxia, of course, there's going to be a problem with the vestibular nucleus. There's going to be a problem with the nucleus ambiguous. And, I misspoke. So all of these throat kind of symptoms are due to the nucleus ambiguous, because that's cranial nerves 9, 10, 11. The ataxia is due to the cerebellar peduncle and the vestibular nucleus. Giddiness is going to occur due to the vestibular nuclei being activated, and it's because like this person's on a constant rush. So whenever you are on a roller coaster and there is that spike of adrenaline because of the dizziness, especially when it goes in a loop. I mean, some people don't enjoy it, but there's still a rush. You can't deny it. This person's going to feel this all the time. Like every time they stand up, every time they move their head, there's going to be that rush. Okay, so Dejeron's anterior bullbar syndrome is the full name. It's going to affect the medial medulla. especially the perimedial area, and involves the pyramidal tracts, the medial lemniscus, and cranial nerve number 12. So what's going to happen? There's going to be atrophy of the, half of the tongue with deviation to the lesion side because it's involving the hypoglossal nerve. Contralaterally, because it's involving the pyramidal tract, that's the, crossing. There's going to be paralysis of the upper extremity and the lower extremity because of the medial lemniscus, and it's going to have the patient is going to have impaired tactile sensation and proprioception. So they're not really going to know where in space their body is, and they're not going to be able to distinguish like textures very well. Avilisis syndrome is going to be due to the occlusion of the vertebral arteries, usually in the medullary tegmentum area. The lesion of cranial nerves 9, 10, and the nucleus ambiguus, along with the pyramidal tracts. So there's going to be ipsilateral, palatal, and vocal cord weakness thanks to cranial nerve number 10, because remember, cranial nerve number 10 eventually becomes the laryngeal nerves, and then the vocal cord weakness is due to the recurrent laryngeal nerve being affected. There is going to be a loss of pain and temperature contralateral, remember, because the pyramidal tract decussation, so it's contralateral. And occasionally, in some severe cases, there's going to be the hemiparesis, but in general, is more loss of pain and temperature. Okay, in Jackson syndrome, there's going to be a lesion in the medullary tegmentum, and is either caused by an infarction or a tumor. It's involving the cranial nerve 10, along with the nucleus ambiguus, and then cranial nerves 11, 12. What's going to happen? There's going to be flaccid paralysis of the soft palate, pharynx and larynx, thanks to cranial nerves 11, 12. There's going to be hypoglossus, so this is going to be a problem with cranial nerve number 12 and some of cranial nerve number 10. Flaccid weakness and atrophy of the sternocleidomastoid muscle. Trapezius is going to be due to the problems with cranial nerve number 11, the accessory muscle, the tongue, cranial nerve number 12, and extramedullary multiple cranial nerve palsy, thanks to the involvement of the nucleus ambiguus. So the palsy is going to happen outside of the medulla, but since it's all kind of relaying through the nucleus ambiguus, it's going to have these medullary, it's going to be caused. So the cause is inside of the nucleus ambiguus, so inside the medulla, but there's going to be the palsy relating to the nerves going outside of it. Okay, so Schmidt syndrome is a lower medullary tegmentum syndrome, and there's going to be a problem with the nucleus ambiguus, the bullbar and spinal nuclei of cranial nerve 11, and or their radicular fibers. So what's going to happen? Ipsilateral paralysis of the soft palate, pharynx, and larynx, thanks to cranial nerve 11, and the nucleus ambiguus, the flaccid weakness and atrophy of the sternocleidomastoid muscle and the trapezius due to cranial nerve 11 again. And then there's going to be vagoaccessory syndrome. So vagoaccessory syndrome, problem with the vagus nerve, so cranial nerve number 10 is going to be affected, and the accessory nerve is going to be affected. So this person wouldn't be able to, they're going to have a hoarse, raspy, or a non-existent voice, and they're going to have problems shrugging their shoulders and turning their neck. So that's it for now. Thank you for your attention, and good luck studying.